When the thyroid is low and not functioning properly, everything slows down. And as a result of everything slowing down, this can have a variety of biological and psychological consequences. If someone has an autoimmune condition or they have poor diet and lifestyle practices which are causing thyroid issues, these will not. Okay, everyone, I hope you are all doing well. Welcome to my Thyroid Masterclass. There is a lot for me to go through here today with you, and I'm going to start with a few introductory points, a little bit of housekeeping, and then we are going to get straight into this. I've been wanting to make this video for a very long time. There was a lot to get onto the slides and to communicate with you regarding the thyroid and everything about the thyroid. The thyroid is a pretty complex topic. And what I wanted to do today was make a masterclass that is not just applicable for men. It is catered more towards men, but the thyroid is a universal hormone for both men and women. But this is also not specifically just for men on TRT. This is for anyone wanting to learn about the thyroid, but I will be referencing TRT at some point. So without further ado, let's just get straight into this. So the thyroid is an essential driver of the body's energy metabolism, primarily the glucose metabolism. Now, the thyroid in many instances is a more complex thing to work with than testosterone replacement therapy. This is because it can involve an autoimmune component, and some patients will have an autoimmune condition known as Hashimoto's thyroiditis, which I'm going to explore more in this lecture today. And in the advanced and untreated stages of this, the patients may have even had their thyroid removed, as well as potentially thyroid cancer. There are many different opinions on thyroid treatment, testing, diagnosis, and optimization. And I'm going to take this point just to do a quick bit of housekeeping. If you disagree with my stance or opinions on thyroid in this lecture, that is totally fine. People do things differently. The thyroid is not fully understood. We only know what we know about the thyroid at the time of recording this lecture. So more information may still come to light in the future of science regarding the thyroid. And if you disagree with something in this lecture or you have a different stance, that is totally fine. But whinging about it in the comments and having an emotional breakdown about the fact that I said something about science that you don't agree with is probably not going to really help either of us, especially not help you. So keep that in mind. Now, this masterclass will present my approach to treating hypothyroidism in men. My background is biomedical science. I have been working in the TRT and hormone optimization space now for many years, and I'm going to attempt to teach you everything I know about the thyroid, both for patients and for practitioners. Many principles in here will be relevant to women, but the primary focus of this lecture will be for men. The reference ranges and numbers spoken about will be for men. However, many of these points will be applicable to women as there is a lot of overlap in the treatment of male and female hypothyroidism. This is not the only way to treat hypothyroidism. This is my approach based on years of working with clients, as well as independent research and a foundation, as I said previously, in biomedical science. So my opinions and approaches have changed and evolved over the years based on experience. And if you are new to the field or you are a patient first learning about the thyroid, you may find that you change your opinions and approaches as you go as well. So this is probably going to be long. So for a summarized 101 style presentation of this topic, you can refer to the Beyond TRT ebook. And I've also done a free lecture of this ebook, which is available on YouTube as well. And I'm going to have my videographer put that content here on the screen for you. The content in the ebook and the lecture is the same. So if you do not have the money for the ebook, it is very affordable. But if you prefer to have it in a lecture format, if you prefer a quick listen, you can check out that version if you're not interested in watching whatever the length, the timestamp of this video says it will be. But this is going to be a lot more in depth. Now, this lecture is not medical advice. Please understand this. This is designed to inform patients and practitioners, not to diagnose or treat any conditions. I am not a doctor, as I said. I am a scientist and a health coach, and the information presented is purely educational. For the rest of this lecture, I am going to imply this point. I'm not going to keep repeating this. So for the future of this lecture, please assume and please take the interpretation of the information purely as educational advice. Now, if you require thyroid treatment, you can contact my partner in clinic in the US, Victory Men's Health. You can also work with my clinic over in Europe, TRT Baltic. In the UK, I also recommend working with Dr. Max Draper at Alphagenics. I am sure there are many other people you can work with. You can work with my friend Justin Grosset or Gross. I'm not sure how to pronounce his surname. I really need to ask him how to get that correct, but I am sure one of those two is correct. Justin is fantastic as well. There are a lot of fantastic thyroid practitioners. I cannot list them all, but those are the people who I recommend working with if you would like to contact someone. Now, I'm going to explain these topics in much more detail as I would in the Beyond TRT lecture, because it is required to communicate everything that I need to teach you today. So this may be a little bit in depth. This may feel a little bit bogged down, but I want to teach you everything. However, I do need to simplify some concepts for the sake of not having this lecture take all day. So I'm going to provide every detail that I think is relevant for you to understand what you need to know, but I'm not going to explain every single tiny little thing about everything involved with the thyroid, as that would simply be an 8-hour lecture. So as I said, this is going to be long. I have 6 years of in the trenches experience with troubleshooting these scenarios and hypothyroidism, and I want to teach you as much as I possibly can. So here are the key foundational concepts. That was enough of an introductory preamble. I am sorry if people are already bored, but buckle up. You may be more bored as we go. So the thyroid primarily produces the hormone T4 as well as a little bit of T3. The body then metabolizes this primarily inactive form of thyroid hormone called T4 into the more active hormone, or the primary biologically active thyroid hormone T3, in various tissues in the body. Primarily, this is done in the liver, but this is also done in the kidneys and the brain. So if your liver health is not optimal, your thyroid hormones will not be optimal, as the liver is the primary place where your body converts T4 into T3. So T3 is a primary contributor to your body's basal metabolic rate. T3 has integral components as well as neurotransmitter production and regulating stress hormones in the body. It is a key component in the activity of dopamine transmission, and therefore I would argue that it has a neurosteroid component as well. Now, people often say these words quickly, so I want to get a little bit bogged down on the definitions here so that people really understand what this means. So hypothyroidism with an O means underactive, whereas hyperthyroidism with an E means overactive. If people say hypothyroidism really quick, it can sound like either or, but these are two opposing and drastically different conditions. So hyperthyroidism with the ER overactive is much rarer than hypothyroidism, meaning underactive. This is a serious medical condition, and I am not focusing on that today in the masterclass. This is very different. So this lecture is going to be focusing on the treatment and diagnosis of either full-blown hypothyroidism or subclinical hypothyroidism. Again, hypo meaning underactive. Now, thyroid issues may be primary, related to the thyroid gland itself, or it can also be a secondary issue, primarily with T4 to T3 conversion, as well as thyroid hormone receptor resistance. This is an important distinction because different treatments are indicated for different presentations of hypothyroidism, and secondary hypothyroidism will require a much more holistic intervention in order to be effective. Now, holistic can sometimes get a bit of a bad reputation because a lot of people will, I guess, pitch or pose esoteric or non-evidence-based solutions as holistic. But when I say the word holistic, I mean treating the body as a whole series of interconnected systems, which is ultimately the foundation of human biology. So many patients diagnosed with depression, anxiety, inattentive ADHD, dyslipidemia, meaning your lipids are out of whack, or a slow metabolism, have subclinical hypothyroidism. Again, I want to circle back to this point before we move on. This is not the only cause of these conditions, but many people who are diagnosed with these conditions based on their symptoms have roots in subclinical hypothyroidism, and it is often overlooked both in terms of testing and in terms of diagnosis. As I said, the body is a complex series of interconnected systems which regulates your consciousness. So your consciousness being the thing that is listening to these words and interpreting this lecture inhabits your physical body. And there is an interconnected feedback between the body and the mind and the body. This is the most esoteric thing I will say today, I promise, but this is an important thing to understand. The body is not a robot, but you are also sentient, and this has a very complex interplay that often gets overlooked. So when the body is not able to efficiently and effectively burn energy, which is your metabolism, short-term and long-term problems will occur. This is biological stress. So untreated hypothyroidism results in various mental health conditions, as well as cardiovascular disease, insulin resistance, infertility, IBS, which is irritable bowel syndrome, SIBO, which is small intestinal bacterial overgrowth, constipation, insomnia, and many other symptoms we commonly associate with low testosterone. When the thyroid is low and not functioning properly, everything slows down. And as a result of everything slowing down, this can have a variety of biological and psychological consequences. So hypothyroidism must be evaluated before initiating TRT. I cannot stress this enough. And also while on treatment. This is the importance of doing comprehensive lab work and working with a practitioner who actually knows what they're doing beyond just looking at the androgen system of the body. So low androgens can cause subclinical hypothyroidism, which may be rectified by TRT. However, autoimmune thyroid conditions, as well as poor diet and lifestyle, will continue to cause thyroid problems. The thyroid output can also decline with age, which is why many men who have age-related hormone decline don't just need to top up their testosterone levels, but they also need to support their thyroid, pregnenolone, DHEA, melatonin, growth hormone, etc., which is individual and case by case. So if someone has an autoimmune condition or they have poor diet and lifestyle practices which are causing thyroid issues, these will not be corrected just by injecting testosterone or rubbing a testosterone cream on your scrotum. The systems are interconnected. They are not codependent. So if you fix the testosterone and the only cause of the low thyroid is the low androgen levels, this will support it. But if your thyroid issue is coming from secondary health problems or an autoimmune condition, not only will TRT not fix this, but it may stress this system further, making these symptoms worse. TRT will not cause you to have hypothyroidism, but if you have hypothyroidism already, TRT can shine a light on these symptoms because it is now putting more stress on the system that was already malfunctioning. It's like if your car needs a service and you just upgrade the engine, you may find that the other faulty parts of the machine are now showing symptoms because there is more power and more energy being driven towards a part that already needed support. So, severe hypothyroidism will lead to lowered androgen production, and correcting this beforehand may even prevent the need for TRT. And untreated hypothyroidism is one of the most common causes of side effects on TRT that I see. And again, this was covered in Beyond TRT. I have also got a troubleshooting TRT lecture, which I'm going to put here on the screen, and you can check that out as well to understand more overlooked or underdiagnosed issues which lead to these side effects on treatment. Now, I'm going to get into something that is a little bit of my opinion here. So I believe, and again, this is my belief, many of the endocrine disrupting environmental factors, the plastics, pollutions, and the pesticides, are also impacting thyroid locally as well as at a receptor level. So thyroid function declines with age. Now we're getting back into the facts. And it is common, as I said before, for men with age-related hormone decline to benefit from thyroid augmentation in addition to their TRT. Optimal thyroid and optimal androgen levels work synergistically to optimize treatment outcomes. And I'd like to give credit to my friend Jay Campbell. Jay Campbell has been harping on about this for many years. He has spoken about this in podcasts quite prolifically, and you can check out his book, The TOT Bible. So let's talk about some common practices. So the most common treatment for hypothyroidism is unfortunately T4 monotherapy, which is also known as levothyroxine. Now, the most common lab test for assessing hypothyroidism is unfortunately simply running a TSH, which is thyroid stimulating hormone. Both this treatment and this diagnostic criteria are ineffective most of the time. Now, again, there are many patients who do fantastically on T4 monotherapy. And if T4 monotherapy is working for someone, if it ain't broke, don't fix it. But the majority of people, in my experience, do not optimize their thyroid function with T4 alone. And I'm going to explain why this is further in the lecture. But just like the sky is blue, this is clear regardless of the mechanistic theory behind this. So many patients have poor treatment outcomes with their thyroid therapy due to T4 monotherapy, or they have undiagnosed hypothyroidism because the thyroid is not being properly assessed. So their TSH may be normal or within range, but you can have quite rampant thyroid issues even with this level being quote unquote normal. So hypothyroidism requires multiple lab markers to assess. A complete thyroid panel to assess hypothyroidism is as follows: TSH, which is thyroid stimulating hormone, free T3, free T4, anti-thyroid peroxidase antibodies, anti-thyroid globulin antibodies, which are the two antibodies we assess for autoimmune thyroid condition called Hashimoto's, as well as reverse T3, which is a little bit controversial, and I'm going to cover this later as well. Now, some patients, as I said, do respond well to T4 monotherapy, but these are a minority. Natural desiccated thyroid, which is what is commonly referred to as NDT, and I'm going to refer to this as NDT for the rest of the lecture because there are less syllables. Now, natural desiccated thyroid, NDT, or T3 and T4 combination therapy is the gold standard of thyroid treatment. There are pros and cons to each option, and good practitioners need to have both these tools in the toolbox because not everyone will do well with NDT and not everyone will do well with T3 and T4. And if you work internationally like me, not everyone can access both of these medications. There are pros and cons to each. I'm going to explain why I believe natural desiccated thyroid is superior in most cases, but it is far from a one-size-fits-all, both mechanistically and in practice. But T4 monotherapy on its own is not the gold standard. T3 monotherapy is not either. Patients often require T3 and T4 or natural desiccated thyroid, which contains both of these, as well as other biologically active compounds, which I'm going to discuss. So, as I said, an effective practitioner must have both of these medications in their toolbox, as some patients will respond well to one and not the other, and there are various circumstances which may benefit one over the other as well. So, I'm going to go through each of these markers that I spoke about. Thyroid stimulating hormone. This is part of the body's feedback loop to balance thyroid production against thyroid receptor activation from T3. This is how the body, when the thyroid is functioning properly, maintains homeostasis of thyroid hormones. So when the thyroid is functioning optimally, T3 reduces TSH expression. And in these healthy patients, T3 will be high and TSH will be low, and there will be no hypothyroidism symptoms present. The latter part is very important. So this is a signal that the body is receiving enough thyroid hormone at the receptor level. Now, this feedback mechanism does not always work properly. This can be due to thyroid dysfunction or due to pituitary dysfunction, which is why it is ineffective in isolation, but it is still useful to look at as part of the full picture with some patients, but not others. As you may have identified by now, this is more complex and less straightforward than a lot of aspects of TRT. Now, if we're going to look at T4, T4 is primarily, and I say primarily, not solely, a precursor hormone. And this allows the thyroid hormone to be delivered into various tissues and then metabolized into T3 via a rate-limited process. So this is called, in layman's terms, a bottleneck. So T4 crosses into some tissues more effectively than T3, and this allows the body to maintain a steady production of T3 locally. So many patients who use T3 monotherapy in too high of a dose end up becoming deficient in T4, which will then lead to improvements over baseline hypothyroid status, but there can still be some incomplete symptom resolution. The body does require some degree of circulating T4. It is not an inert, useless hormone. So oversupply of T4, particularly in cases where the patient is stressed physiologically or psychologically, will lead to an increased production of what's called reverse T3. Now, patients with primary or secondary hypothyroidism often do not optimally convert T4 into T3, which creates a bottleneck that is not therapeutic or optimal for the body. This throws you out of balance. This is why a combination of T3 and T4 is required in most cases to optimize hypothyroidism. However, there are cases for T3 monotherapy, which I'm also going to discuss. So, to put it very simply, T3 is the active thyroid hormone. It's the thing that does thyroid stuff. T3 has a much shorter half-life than T4, and T3 monotherapy, when utilized, if this is what the patient is requiring, should most of the time be split dosed for optimal outcomes, not just due to the half-life, but due to maintaining stability in the pharmacodynamics of the hormone. My friend Dr. Todd Lee has spoken prolifically about the importance of not just the half-lives of hormones, but maintaining stable concentrations. I would recommend checking out his videos to learn more about the importance of assessing the peak and trough dynamics of a hormone rather than looking at the half-lives. Half-lives are more important for medications, but when we're looking at optimizing hormones, we also need to look at how these hormones distribute in the body over time. So both thyroid hormones absorb significantly better on an empty stomach. Both T3 and T4 do, but T4 is most inhibited by particularly calcium. So a lot of the time, medications or supplements will say, take this on an empty stomach or take this with food. And a lot of the time, it doesn't really matter that much. Sometimes it does. But when it comes to thyroid, it is very important to take this on an empty stomach. You put it on your bedside table. When the alarm goes off, you take it with some water. You don't take it with black coffee. You don't take it with a sugar-free Monster. You take it with water, and then you wait to consume whatever else you're going to consume after the thyroid has had time to absorb. They say an hour. I think 30 minutes is often sufficient, but giving it time to absorb will increase the outcomes of the thyroid hormone due to how it metabolizes and how other things in the stomach may compete with absorption and metabolism of the hormone. A healthy thyroid, which is often referred to as euthyroid, not YOU, EU thyroid, individually produces a ratio of about 3:1 T4 to T3. Now, porcine thyroid, which is from pigs, which is what is primarily used in NDT, is a 4:1 ratio. This is not perfect. Humans are not pigs, but it is close enough that it will often deliver optimal treatment outcomes. So it's important to note that T3 burns everything. It doesn't just burn fat. So if you take too much T3, whether it's endogenous, meaning it's produced naturally in cases of an overactive thyroid, which, as I said, is rare, or exogenous, meaning you're taking it orally, can have a catabolic effect, meaning breaking down muscle tissue. So too much T3 will also elevate the heart rate, it will cause excessive sweating, and it will cause overstimulation of the peripheral nervous system. This is kind of like when you have too much coffee. Too much stimulation, not in a good way. T3, like many things, has what's called an inverse U-shaped response. Now, the layman's term for this is a sweet spot, or we can also call it the Goldilocks zone for people who like fairy tales. So just like if you stay up all night, no coffee can be bad, and 20 cups of coffee can be bad. They are bad, but in different ways, and there is a sweet spot in the middle. Again, this is an analogy. Staying up all night is not healthy. Coffee doesn't fix sleep deprivation, but I think people can get my point here. So too much of a good thing is not a better thing. This applies to many things in life, but particularly endocrinology. So I want to touch on reverse T3. Now, reverse T3 blood testing is often very expensive. I prefer all my clients and clinics, where possible, to test for reverse T3, but it can be cost prohibitive to do this prophylactically, I mean doing it preventatively. However, in my opinion, if it needs to be tested, it needs to be tested. Now, I know many people, in fact, many people who are my colleagues and my friends who I respect, who will say reverse T3 is useless. I respectfully disagree. Now, it's important to note that all tests are useless if someone doesn't know how to interpret and apply them properly. It can also be redundant if the provider does not need to measure this lab marker in order to deliver the outcomes they're looking to achieve. So there is some nuance here. Not everyone who doesn't test reverse T3 is incompetent. Absolutely not. But as someone who is conservative and has the mindset of test, not guess, I prefer to test it, but also to be able to communicate with clients, or if you're a practitioner, for your patients, so that they can understand what's actually going on in their body. Because reverse T3 can be very useful for educating patients to see what the root cause of their low metabolism is. So, as I said, some practitioners may be able to predict reverse T3. And this can be identified as most likely being problematic from elevations in things like TSH alongside elevated T3, hyperlactin, high cortisol, symptoms of chronic stress. But for me personally, where possible, I'd rather just test it. So reverse T3 is a very well-named hormone. It's very well named. It looks like T3 molecularly, and it competes at the receptor with T3, but it blocks T3 from exerting a biological effect. Now, reverse T3 has a lower binding affinity than regular T3, so it doesn't completely block all of its activation, but it competes enough that it slows the body's metabolism. This is not a glitch, this is a feature. So this is the body being able to intentionally slow your energy metabolism in a state of stress to conserve resources for survival. Whether you believe in creation or evolution or a combination of both, I don't really care. But we can all agree that there has been at least a period of human time prior to the agricultural revolution, and especially the industrial revolution, where the primary concern for human survival was conserving energetic resources. Food was a scarcity. Now it's an abundance, which creates a new problem. But the body is very good at slowing your metabolism for survival, and it is done via reverse T3. This is the body's biological pathway of doing this. So reverse T3 is basically your body coming in and pumping the brakes. Now, if you think of yourself as a car, you can understand that if you come in with exogenous T3, so in this case, you pumping the accelerator, if your body's pumping the brakes and you're pumping the accelerator at the same time, you're not going to have a smooth ride forward. You might make some improvements, but you'll also have some side effects. It's going to be a bumpy ride. This is when you solve a problem and create another problem, or you solve two problems, but then you create one in its place. So oversupply of T4 will inevitably increase the production of reverse T3 to some degree, even if the individual is not stressed, due to enzymatic bottlenecks. The body can only convert so much T4 into reverse T3. It is excuse my French, a shit-framed perspective of human biology that you can simply correct a deficiency in T3 by just providing a bunch more of the precursor hormone into the body. It shows a lack of intrinsic understanding of how human biology and the endocrine system work. So T4 monotherapy will often not work because the amount of T4 that the practitioner gives the patient is not able to be efficiently and effectively converted into T3 because of the underlying issue that caused the hypothyroidism in the first place. It is very rare for the individual just to have a T4 production issue, but It is present in some cases. Exceptions don't disprove rules. This is how science works. This is a very, very clear method in science. People need to look for a 95% confidence interval. You can look up what that means. Exceptions don't disprove rules. Every rule has an exception. And if every exception disproved every rule, we wouldn't have any rules or ways of understanding the world. Now, reverse T3 should always be as low as possible when optimizing hypothyroidism. There is no benefit to having an oversupply of reverse T3 if we are looking to optimize thyroid function. Now, the root cause of elevated reverse T3 must be assessed. You can't just work around it and flood a bunch of T3 and solve the problem. It doesn't work, as for the reasons I said before. Also, again, reality. So we have to identify and ideally treat why the body is overconverting T4 into T3. This must be identified, this must be treated, and this must be assessed properly. Now, the problem that we can have is if the root cause of this is what's called intractable, meaning it can't be fixed. So in these instances, let's say someone has severe injuries, let's say someone has multiple bulging discs or a surgery that's gone wrong that's causing chronic pain and inflammation, for example. There can be others. In these cases, a small top-up of thyroid may be warranted in conjunction with other practices, supplements, or even medications to mitigate the excessive conversion of reverse T3. So this is kind of like taking the foot off the brakes as much as possible while putting the foot on the accelerator a little bit. This works well. It's not ideal, but if someone has an intractable condition, you have to work with the patient where they're at. This is where low-dose T3 monotherapy can be indicated, but it has to be part of a holistic regime. Again, I'm using the H word. So T3 monotherapy, as I said, is not a workaround. It is not a panacea for high reverse T3. This is simply a lack of understanding of how the body works. And if practitioners who do this listen to their patients, they would also discover that most of the time it doesn't deliver optimal outcomes. So we're going to move on now to Hashimoto's. Hashimoto's is named, as people may have guessed, after a guy named Hashimoto. It was named after the late Dr. Hakura Hashimoto, who discovered the origins of the disease. Now, antithyroid globulin and antithyroid peroxidase are the two antibodies produced by the body when the immune system attacks the thyroid. So Hashimoto's thyroiditis is the diseased state of the thyroid as a diagnosis, which is the result of the autoimmune attack and subsequent damage to the thyroid gland. Hashimoto's causes symptoms in early stages, even when TSH, T3, and T4 are in range. So the late stages of Hashimoto's are far more obvious in the blood work because there is a more severe stress state that will typically result in a drastically elevated TSH. So ATPO and ATG, which are the antibodies I mentioned before in their abbreviated titles, are cheap lab tests. And these, in my opinion, should be included in routine HRT onboarding as part of a comprehensive lab test. This is my tip to any clinic owner, any doctor, any practitioner who's getting into the space. I have been doing this for a long time, and I have seen a lot of clients with Hashimoto's that is overlooked because their TSH, T3, T4 levels look relatively normal, but they are having symptoms. The symptoms will just be milder because it is in the early stages. But in my opinion, and it's very difficult to argue to the contrary with this, it is better to treat it early with low doses of thyroid hormone to prevent the condition from getting worse over time and the patient suffering with the health consequences of this. It's kind of like if your check engine light comes on in the car, it makes sense to take it to a mechanic before the engine starts billowing smoke. So Hashimoto's may be present, as I said, when these antibodies are elevated, but within a lower end of the range. So even if someone's antibodies are present and maybe they're at the top of the range or slightly above, or even one of the antibodies is elevated, this can still indicate in some cases Hashimoto's. However, there are also patients that will have a slight expression of these antibodies when they do not have hypothyroidism. So this is why it's important to assess for symptoms. A quick side note, it's more acceptable culturally to say this now, but I've been saying this for a long time. The COVID vaccine did cause some elevations in ATPO for a lot of people. It caused them to be elevated within the range, but it did not induce Hashimoto's in people who did not already have this condition, in my experience. But that is something that is worth identifying if you do see some mild elevations popping up time to time in your patients. Now, low-grade elevations in ATPO and ATG antibodies, as I said, and I will reiterate this, do not necessarily indicate Hashimoto's. It doesn't necessarily indicate that this will progress, but it should be monitored. ATPO and ATG antibodies may be slightly elevated in euthyroid individuals. And this is, again, very important that this does not mean that this will lead to increasing levels over time, but you should still monitor it. So, Hashimoto's is still not fully understood. And I am going to present my understanding of Hashimoto's, but there may be some disagreements on this. Now, what we do know is the propensity to develop Hashimoto's is genetic, and it is often activated by an acute stressor or chronic stressful conditions, which is quite similar to how other autoimmune conditions develop. There is some emerging research as well as some decent clinical data to suggest that issues with gut dysbiosis can also be a factor that contributes to the antibodies elevating, with pathogens getting into the bloodstream through the gut mucosal lining when it is compromised. But I think this area of science needs more exploration, but I am going to flag it as something that people may want to look into, but it is not part of how I diagnose or treat Hashimoto's personally, but it may be for you. So Hashimoto's is commonly inherited from the mother, but it can absolutely also be passed on via the father. Now, anyone with Hashimoto's hypothyroid parents, as a result, should definitely be assessed for hypothyroidism, especially if symptoms are present. This kind of goes without saying. So, hypothyroid symptoms, which we're going to talk about now, primarily present via the consequences of a lowered metabolic rate and impaired glucose metabolism. This results in downstream consequences, which create the symptoms that we commonly see in practice. There are also secondary direct consequences of reduced T3 receptor activation, however, which impact other systems in the body, such as the brain, such as conversion of testosterone to estrogen, and the expression of androgen and estrogen receptors. It goes very, very far-reaching through human biology, which can create and exacerbate further negative symptoms. The most common hypothyroidism symptom that you will see discussed online or in your handbook if you're a doctor, or in forums or with ChatGPT or whatever else people are using these days to think for them, is cold extremities or an increased sensitivity to cold, the inability to sweat while training, etc. However, as men have a higher basal temperature than women, this is not sexist, this is just a fact. Hypothyroidism is more commonly diagnosed in women via these symptoms, but it is often not the first sign and symptom in men. In fact, if this is present, it can be an indication that it is more severe in men. Again, this can be a secondary issue. However, if someone has cold extremities and low thyroid function, it may be secondary due to stress. This is why it's important to have it properly evaluated and treated. Hypothyroidism is not the only cause of cold extremities. And this is also very important because this can be caused by mobility issues. It can be caused by poor circulation, and poor circulation is often caused by lack of cardiovascular fitness. So if you have cold hands and feet, it doesn't mean you have hypothyroidism, especially if you don't do cardio. But a good practitioner will be assessing and looking at everything. So hypothyroid symptoms are very similar to hypogonadism symptoms. In fact, they're virtually identical. So if you take a Venn diagram, which is two circles that cross over in the middle, and you put hypothyroid symptoms on the left and hypogonadism symptoms, meaning low testosterone, on the right in men, these will be basically all in the center of the Venn diagram. There are some symptoms that are more pronounced with one or the other, but the symptoms are basically the same. And this is why it's so important that this gets assessed, because these pathways are interconnected and the symptoms are interconnected. There's so much crossover. So if someone wants to practice testosterone replacement therapy, they have to also be able to practice treating and optimizing the thyroid. Problem is, this one's more difficult and it's not as marketable. So thyroid and testosterone impact many of the same neurotransmitter and biological pathways. It is a common misdiagnosis of hypothyroidism for adults to be diagnosed with inattentive ADHD due to lowered glucose metabolism and lowered dopamine transmission in the brain. Again, I can already sense that someone is going to cry about this in the comments. So just to reiterate, 1, I'm not going to read it. 2, I don't care. But this is not the only cause of this diagnosis, but it can be a misdiagnosis a lot of the time. So other common hypothyroidism presentations include the following: excessive fatigue, insomnia. Again, this can be a bit of a paradox, but because hypothyroidism will lead to hypoglycemic episodes overnight, this can cause low sleep quality, but some people with hypothyroidism simply can't get out of bed. Hair loss, slowed digestion, bloating, constipation, as well as SIBO and candida overgrowth. This is a consequence of slowed gastric motility. The shit literally ferments for too long and it causes issues in the gut. Also, if the shit is moving through the bowel too slow, it will dry out and you'll become constipated and bloated from the fermentation of the gas. Excuse my French. So, anxiety and depression, lowered libido and sex drive, exercise intolerance, poor recovery, slow metabolism, and the inability to lose weight. Now, again, these things can be caused by many other diet and lifestyle factors or other disease states. These are relatively ambiguous symptoms, but given these symptoms are so ambiguous and so prevalent, this is why I am making the case that this should be part of a routine assessment for anyone wanting to optimize their health preventatively, anyone who is focusing on improving their quality of life and a better subjective experience of being a human, as well as anyone who's wanting to optimize their hormones. If you want to optimize your hormones, you can't just look at one hormone. This doesn't make any sense. If you want to service and upgrade your car, you can't just look at one aspect of the engine. So when it comes to hypothyroid symptoms, I'm going to make a little bit of a dig at personal trainers here. I have nothing against personal trainers, but people need to recognize their area of expertise and their limitation of understanding. So many personal trainers will not recognize that hypothyroidism lowers total daily energy expenditure, or TDEE. This is why many clients will not lose weight when they appear to be in a caloric deficit. So calories in, calories out, the laws of thermodynamics, is like saying water is wet as a solution to not drowning. It is a foundational principle. It is not the be-all, end-all solution. So calories out will be determined by a lot of biological factors. And while many people will blame a poor thyroid, which they don't have, for overeating and underexercising, there are many people who are training well and eating well and do not lose weight because the calculator that the personal trainer has entered their caloric requirement into is inaccurate because they have low thyroid function. Further caloric restriction will then cause malnourishment and increased reverse T3 conversion, as well as increased cortisol and adrenaline production, leading to muscle catabolism. This is when people, when they bulk, they will get fat, and when they cut, they will lose muscle. So as a result, clients will often become discouraged and unmotivated from training because they're told that the reason why they're not losing weight is because they're not tracking their sources properly or something else redundant like this. So it is very important, if you are a personal trainer listening to this and you are having clients plateau, that you refer them out for blood testing to see if there is a biological issue underpinning their progress before you blame their intensity and nutrition. Now, hypothyroid patients will often self-medicate their symptoms with fasting or low-carb diets, but will crash after eating and will feel okay, but never good, as these approaches don't treat the root cause. So what will often happen is that people who have hypothyroidism will become lethargic and crash even after eating a healthy amount of good carbohydrates. So as a result, they will favor their fat burning system via low-carb diets, ketogenic diets. However, when they do eat carbohydrate or they do eat protein in excess, they will then crash their energy levels and feel like garbage. So working around this dysfunctional process is not healthy. It's a band-aid, but it is a short-lived, ineffective band-aid at best. So over time, hypothyroidism will lead to insulin resistance and metabolic syndrome. This is why these short-term solutions don't work in the long term. So hypothyroidism is a very commonly overlooked cause of dyslipidemia, meaning bad lipid profile. So hypothyroid patients often have low self-esteem, as no matter what they do, they feel lethargic, and it requires stress for them to even do basic tasks, leading to poor outcomes in relationships, hobbies, and careers. I'm going to come back to my car analogy again. If you have a car that has an engine that's too small for the vehicle, that is in desperate need of a service, it doesn't feel good to go and drive that car. So you're only going to drive it when you have to. You're not going to take it for a joyride. This is one of the issues with hypothyroid patients, is that they feel like crap all the time. The medical term for feeling like crap all the time is called malaise. So when someone feels like garbage and needs stress to get off their ass and do anything, this leads to low self-esteem because they feel like a failure. They feel like they're behind the 8 ball. And then it doesn't feel good for them to go for a walk or go for a run or move their body. It feels stressful. It makes them feel worse. So this leads to very different trajectories over the course of 5, 10, 20, 30 years. And when they get into later stages of adulthood, they feel like they're the ones to blame because they couldn't do what other people around them are doing. And this can be very demoralizing. So hypothyroidism will drastically reduce quality of life, both subjectively in the short term because you have low energy, but also in the long term because your outcomes are negatively affected. So we're going to move on to treatments. So as previously stated, the frontline treatment for hypothyroidism is typically T4 monotherapy in doses of 25 micrograms up to 200 micrograms, which for most cases does not provide optimal symptom resolution due to incomplete T3 optimization and increased propensity to convert T4. Also, if someone has hypothyroidism, 25 micrograms of T4 isn't going to do much of shit. So hormone gland dysfunction cannot be corrected by just supplying precursor materials. If you don't know how to build a house and you're homeless, if I give you a bunch of building supplies, it's not going to solve the issue. So I often see iodine and selenium are recommended by naturopaths or holistic doctors. However, these will not increase thyroid output in a linear fashion. So they will only provide benefit if the body is deficient in these nutrients, which is uncommon. So I recommend all my clients, and I recommend that everyone's patients takes a good quality comprehensive multivitamin that contains iodine and selenium in it anyway, in appropriate physiological doses. I don't recommend megadosing iodine. I've had a whole bunch of people cry about this. It's not healthy. It's incorrect. I've watched the lectures. I've read the science. If you want to take a megadose of iodine, go for it. Don't come crying to me about it when it doesn't work out, though. I don't recommend people do this. But I have never, in my entire career, ever seen a case of actual hypothyroidism resolved from selenium and iodine. Mechanistically, people might think that this makes sense. It doesn't. It doesn't work. It doesn't work. It doesn't work. It doesn't work. If someone has full-blown hypothyroidism, iodine and selenium are not going to fix the issue. So again, I'm going to come back to this megadosing iodine thing because I did put it in my slides. I have seen people recommend on YouTube that people take 1 to 2 milligrams or even up to 12 or 50 milligrams of iodine per day. This produces toxicity, and the toxicity is often dismissed as the body detoxifying. This is really, really wrong and dangerous and dumb. Also, I'm just going to correct it. If people are watching someone on YouTube saying methylated B vitamins resolve Hashimoto's, no, it doesn't. No, it doesn't. No, it doesn't. So again, if people want to go down this path, all the best to you. It doesn't bother me, but I'm warning people, this is not the solution and you can cause harm to yourself. But if you want to believe in it, go for it. Now, bioidentical thyroid optimization is extremely safe and it's evidence-based. The consequences of not treating a thyroid deficiency are the risk. When the thyroid is properly optimized, it does not shut down natural production, it fills the gap. I wish we could do this with testosterone. So the body is signaling that it needs more thyroid via increased TSH production, and the goal of thyroid optimization should be providing this gap. Not overshooting it means that you can basically top up the gap between what the body is making and what you are producing. I'm now going to magically materialize a bottle of water. What I have in front of me here to explain this is a bottle of water and a glass. Now, let's say you're at a fancy steakhouse or a fine dining restaurant where they keep your water glass topped up at all times. You can think of the thyroid like this. So, when the glass is empty, the waiter is going to come over and pour the water. But when the water starts to get close to the brim, unless he wants to lose his job or lose his tip, he's going to stop pouring the water. This is how the thyroid is supposed to work. So, what we have is various presentations in the lab work, which I'm going to discuss, which come back to this glass of water analogy. So the perfect scenario is when the glass is full, which means the T3 is high, and you're not signaling to the waiter to say, hey, I need more water. That means TSH is low, T3 is high, and everybody is happy as Larry. So, I'm going to come back to this. So multiple research studies have shown that there is no damage or impact to endogenous production when high doses of thyroid are used even for multiple years. Meaning that if your natural production is here, let's say, and you require this much exogenous thyroid hormone, meaning external, every day to top up your levels, you're not deleting your body's capacity to produce the amount. You're topping it up. And even if you were to do that, which I wouldn't recommend you do, research shows that when you stop topping this thyroid hormone up, that the body will then rebound its natural production straight away. There is no damage to the feedback. So, again, I'm going to put this aside and come back to this. Now, thyroid treatment is less invasive due to this feature of the body's endocrine system because you're not shutting your system down, you're topping it up. However, as there can be multiple causes of hypothyroidism, including autoimmunity, thyroid treatments are more varied and require more individual customization than TRT, because now we're working alongside the body's natural production. This can be a blessing and a curse because natural production, it can now be volatile. We can control the external production with consistent dosing, but it is much harder to control the endogenous production, especially if autoimmunity is present. The body can be more like a broken thermostat than just locked into being too low. So today, I am not going to be able to conclusively teach how to treat every single individual thyroid patient. It's not possible. But I can provide guiding principles, education, and templates that you can interpret and understand to apply to your patients. Or if you are a patient yourself, to have an informed conversation with a provider who actually knows what they're doing and can provide practitioners with this intrinsic understanding of thyroid hormone and hypothyroidism. So, while there is substantial variance from individual to individual, when it comes to natural desiccated thyroid, as well as oral metabolism and bioavailability being different, the typical replacement dose, and again, this is a typical replacement dose, is 4 grains of natural desiccated thyroid per day, which is also known as 250 milligrams. Again, this is not 250 milligrams of thyroid hormone that would kill you. This is 240 milligrams of natural desiccated thyroid. Now, if I've lost anyone, and you're thinking, why on earth did he say grains? I looked this up a while ago because I also wanted this. So if you'd like some fun party trivia, which will attract all the ladies at your next cocktail party, natural desiccated thyroid is an older medication. And what was previously measured in grains was related to a grain of wheat. So 60 milligrams of natural desiccated thyroid was weighed at 1 grain of wheat as equivalent. And this is where this term came from. I don't know why we still use this, but I also don't know why in America you measure things in inches and feet and miles, but it is what it is. So 60 milligrams of natural desiccated thyroid is 1 grain. And we often refer to things in grains. So natural desiccated thyroid tablets are available in quarter grain, which is 15 milligrams, half grain, 30 milligrams, 1 grain, 60 milligrams, 2 grains, which is 120, 3 grains, 180, 4 grains, 240. There are also varied brands which will offer incremental tablets. So for example, brands such as Armour Thyroid make a 1.5 grain tablet, which is 90 milligrams. So 1 grain of thyroid, which is 60 milligrams, contains technically 38 micrograms, not milligrams, micrograms of T4 and 9 micrograms of T3. But for the sake of maths, it is much easier to discuss this as 40 micrograms of T4 and 10 micrograms of T3, which is what we often refer to this as. So NDT, which is pig-derived porcine thyroid, contains other lesser researched but yet important thyroid hormone cofactors, enzymes, and other biologically active thyroid hormones T0, T1, and T2, which are theorized to contribute to its greater therapeutic efficacy in the majority of patients at an equivalent dose of T3 and T4. So a lot of the time, a patient will go from taking a ballpark similar dose of synthetic T3 and T4, which is not a bad thing that it's synthetic, it's still bioidentical. But then when they swap to the same dose of T3 and T4 via natural desiccated thyroid, they will often note better symptom resolution and improved lab markers. This is hypothesized, and I agree with this hypothesis, that this is due to the other enzymes and cofactors and other bioavailable thyroid hormones present in this product, which again, I'm going to give credit to Jay Campbell for making me aware of this many years ago. So again, I'm going to come back to this majority term because I don't mean everyone, but for the majority of patients, 1 grain of NDT will produce a greater therapeutic effect than 40 micrograms of T4 and 10 micrograms of T3 in the synthetic form. There will be some patients who do better on the other and they do better on synthetic, and I'm going to explain why that may be the case, but there are absolutely exceptions. So NDT does have a few limitations, and this is why it's important for practitioners to have synthetic thyroid hormone in their toolbox. So NDT is porcine, firstly, so it's not suitable for some patients due to religious reasons. And over-the-counter bovine thyroid, which comes from a cow, is not standardized for a therapeutic dose of T3 and T4. So when you see these over-the-counter thyroid hormone products, you may think that this can replace your natural desiccated thyroid, but this is wrong. This is not consistent or strong enough to be used for clinical hypothyroidism. It's a supplement, but it has no place in a medical setting. So this set ratio present in NDT is beneficial for most patients, but it is not suitable for all patients. This ratio is locked, and some patients will require more T3 and less T4. So the solution for this is T3 can be added to NDT, or a practitioner can prescribe a custom combination of T4 and T3 in a ratio that fits their individual needs. A lot of patients do better with more like a 3-to-1 or even a 2-to-1 or sometimes even a 1-to-1 ratio of T4 to T3. So less T4, more T3. Now, the other thing that I've noticed is that some patients don't metabolize and absorb NDT properly, and they require synthetic thyroid hormone to optimize their levels and have a symptomatic response to treatment. One of the theories is that the antibodies from Hashimoto's could be targeting the natural desiccated thyroid and breaking it down before it's absorbed. This is a hypothesis, this is a theory, but I would also argue that some patients just might not metabolize it properly. They might not absorb it, they might not digest it. That is not known, but we do see it in practice. And I don't think it matters too much why it is. What it shows is that some people need different treatments. So some autoimmune patients may also develop a rash from NDT. So there can be some genetic issues, there can be absorbency issues, there can be autoimmune issues, and these things need to have an alternative treatment option available so that all patients can get a proper treatment outcome. The other part that's important is that NDT is not available in every country. So it's not available in a lot of Europe. It's difficult to get in countries like Australia and the UK. So while it is frontline in the US, the rest of the world may not have this option. And therefore, even though NDT is superior in the majority of cases, it's not available everywhere. And if it's not available, then it doesn't matter. So synthetic T3 and T4 are bioidentical thyroid hormones. So if something is synthetic, it doesn't mean that it's toxic. It doesn't mean that it's not bioidentical. These are synthetic, bioidentical T3, T4. Now, again, they are not hormone analogs. They are bioidentical hormones. So T4 will often come in 50 or 100 microgram tablets, but it's also available in lower and higher dosages, and this is often referred to as levothyroxine. Now, T3 will often come as 20, 25, or 50 microgram tablets, and I've also seen it in 10 microgram tablets as well. Now, this can be compounded in any dose, but these are typically the tablets that you get from the pharmacy. A common brand for T3 that people might be familiar with is Cytomel. So endocrinology guidelines, and I try not to laugh when I say this, often recommend a 10-to-1 or a 15-to-1 ratio of T4 to T3. Given the human body makes a ratio of 3-to-1, this makes no sense. And also it doesn't work. But this is likely attributed to why there's a poor response from many patients who are having thyroid treatment who have it prescribed from endocrinologists. So if you're an endocrinologist and you prescribe T4 in a 10 or 15-to-1 ratio because it says so in your handbook, maybe you should do a bit of research into why that may not be the best solution, especially if your patients are not getting better. So depending on the degree of hypothyroidism, patients may require 50 to 100 micrograms of T4 and 10 to 25 micrograms of T3, and even up to 50 micrograms of T3 in some cases, and some may even require more than that. So I've seen doses in outliers up to 200 micrograms of T4 and 100 micrograms of T3 being required in some cases. So all thyroid hormones are best taken on an empty stomach, as I said, to optimize absorption. Now, it's also important to take NDT on an empty stomach because NDT contains T4. Now, for people who are going to ask the question, whether it's of me or their provider, taking thyroid hormone with food does not prevent the absorption, it reduces the absorption. So when it comes to day-to-day practice and compliance, which is the reality of these things, this is the human experience of life, there will be times when you miss your alarm, you're in a rush, you forget to take your thyroid hormone, and you're wondering, is it okay if I take this with food? As an every now and then thing, it's fine. It will reduce the absorbency by maybe 10, 20, 30%. It's not completely clear. So if this happens time to time, you don't need to double the dose. You don't need to freak out. You don't need to have an anxiety attack. You just take it with the food, but on a regular basis for optimizing the dose and the treatment, it is important that you take it on an empty stomach. For patients who are taking pregnenolone and DHEA in the morning, you can take these hormones with the thyroid because they will not compete with the absorption. But any other supplements, any 0-calorie drink, black coffee, tea, any of this stuff, avoid it. I always have people say, is it okay to take this? Is it okay to take it with this? Is it okay to take it with that? Just take it on an empty stomach. Just do it. Makes it easier. So all thyroid hormones are best taken on an empty stomach. So thyroid hormone dosing, and this is the next point. This should be initiated at the minimal effective dose to gauge how a patient responds. Because we are not wiping out the natural production, we can introduce a minimal effective dose to ensure a proof of concept. So when a low dose is initiated, ideally the patient is going to have very little to no response. This is not a bad thing. It means they tolerate it. Whereas if they have side effects, it may mean that they don't need the thyroid or the body can't handle the thyroid at this stage, which requires more expertise in the diagnosis and the treatment of the patient. But if something is potentially going to have side effects, you want those side effects to be minimal. So start low, go slow, and work up gradually over time. Thyroid can be titrated every 30 to 60 days until symptom resolution is achieved. But as a practitioner is getting more towards fine-tuning the end stages of optimizing hypothyroidism, it can be better to move up in longer increments, anywhere from 8 weeks through to 6 months, to give the body time and to work gradually when the thyroid is 80, 90, 95% optimal. So again, as thyroid treatment is adding to the body's baseline levels, there is no need to aggressively introduce large doses and then wait long periods of time to review it. It is not logical. It is much more logical to titrate in small increments at higher frequency intervals to allow patients to gradually adjust to escalating thyroid hormone levels without overshooting and causing side effects. So let's say, and again, some people don't think coffee is healthy, but again, I'm just going to use the analogy. There's nothing to get upset about. If someone had never drank coffee before and they said, I want to start drinking coffee, you're not going to start them with a triple long Mac. That is not a good idea. Maybe if you don't like the person, it would be a funny suggestion, but that is not a good idea because they will have no tolerance to it. They will be more sensitive to it. It makes more sense to start with like a half shot latte and then work up gradually as the caffeine tolerance sets in to prevent side effects. So if someone did do really well with 3 shots of espresso, but they started with 3 shots of espresso, that may cause side effects, but it may not have been from that being too much coffee or caffeine for that person. It can be because they just had too much too soon. So start low, go slow, build up gradually. Unless someone has had their thyroid removed, I would like to hear a logical counter argument to that. So an appropriate starting dose for NDT is 30 milligrams. Now, again, it could be 15 milligrams if someone has got a lot going on, or it could be 60 milligrams for more severe cases of hypothyroidism. And this can be increased by 30 milligrams every 30 to 60 days based on lab reviews and symptomatic responses. This is a template. This is not the only way to do it. This is not medical advice. If people are going to comment that they forward this as medical advice, you are digging your own grave. Maybe not literally, it's not going to kill you, but it's not the intention of what I am saying. I have this saying 30 every 30, which is the most I like to escalate thyroid by. Again, unless someone has a severe case, 30 milligrams every 30 days, I would deem aggressive as it is. So in an appropriate starting dose of T4 and T3, if that's what the individual is going to use, I believe 50 micrograms of T4 is a good place to start. This is what I've seen work well. And 10 to 12.5 micrograms of T3. The reason why there's variance there is that's half a tablet. So titrating by small, similar increments, depending on labs and T3, T4 levels, is important, and also increasing one or the other may only be required. If the T4 level is robust on 50 micrograms, then simply titrating up the T3 makes more sense, and these things can be adjusted as the patient goes if they are being used interdependently. So, as patients reach closer to optimal levels, smaller increments such as 15 milligrams of NDT, which again is a quarter of a grain, may be more appropriate, with longer titration intervals of 12 to 16 weeks to allow for symptom resolution to occur, because symptom resolution is not going to occur at 30 days. So there is a lag time between the labs becoming optimal before symptom resolution will manifest. So a properly optimized thyroid protocol should only alleviate hypothyroid symptoms and should not cause side effects. You cannot get an amphetamine-like euphoria from optimizing your thyroid. It doesn't work like that. And this approach is also silly, but I've seen some patients try to achieve this and it never works. So it is common for the thyroid dose to be felt more strongly after each titration for 1 to 2 weeks, as the body is more sensitive to new levels of these hormones, which will stimulate the metabolism. So an analogy is, if you start taking thyroid, it can feel like 2 steps forward, 1 step back, 2 steps forward, 1 step back when you put the dose up, 2 steps forward, 1 step back. This doesn't mean the thyroid hormone stops working. It means that the body's receptors have adjusted to it and things need to be topped up. So after this honeymoon effect, sometimes patients will become demoralized or discouraged by this, but it's important to be reviewing them at shorter increments so that the dose can be titrated up. And then as the dose reaches closer to the end goal, this period can be a little bit more elongated to allow for more adjustment over time as the patient is ultimately feeling better. Now, this point's really important because this comes back to the whole thing that we are working with humans, we are not working with machines and robots. It is very common for hypothyroid patients to self-medicate with caffeine and other stimulants. So they may become overstimulated from the thyroid therapy from consuming excess stimulants, which now have the appropriate biological response. This is not the fault of the thyroid. It's that the patient is now receiving the appropriate response of high doses of stimulants. So, for example, if someone is hypothyroid and then they report anxiety and tremors from an introductory dose, if you actually run their proper history and get proper information about their dietary consumption patterns, you may find that they're having 3 cups of coffee just to wake up in the morning, and they're consuming multiple energy drinks and pre-workouts throughout the day because they've become habitually dependent on these stimulants just to function. So now that patients are having a normal response to excessive caffeine or nicotine or other stimulants or whatever they're using, if they're not aware of this and the doctor is not identifying this properly with the patient, then they can misappropriately discontinue their thyroid treatment, or the practitioner can think that the dose is too high. So if someone is consuming more than 150 to 300 milligrams of caffeine a day and they're finding they're overstimulated, it may not be that there's too much thyroid. It may be that the caffeine is actually doing what it was supposed to be doing. So overstimulation from thyroid hormone can be avoided while adjusting dose titrations gradually at the minimal titration step at each interval. This is a marathon. This is not a sprint. Using small increments such as 30 milligrams every 30 days is a rule of thumb for a maximum increased frequency. Less often can be better. So 30 milligrams every 60 days is likely a more conservative option. This is the most aggressive I would recommend that anyone would be. So work up slowly and gradually over time, especially when patients have poor cardiovascular health, they're overweight, or they have metabolic syndrome. Overstimulating people with stressed cardiovascular systems is not healthy, and if it's not necessary, it should be avoided. So patients need to be patient, pun intended, and practitioners need to be conservative and go back to that Hippocratic oath thing of doing no harm. So patients with hypothyroidism are often physically inactive. This is a behavioral adaptation and maladaptive coping mechanism to malaise, which again is the medical term for feeling like shit-itis. So to achieve full symptom resolution, this is again so important, and these holistic areas are so overlooked by traditional Western medical practitioners, is that patients actually need to increase their physical activity, and they need to lead a healthy lifestyle, including diet, resistance training, cardiovascular training, minimal to ideally no alcohol consumption, and proper sleep. You can optimize your thyroid to the nth degree, but if you're not doing these things properly, you're not going to feel well. There are no pills that can make you feel better if you live a poor diet and lifestyle. So patients need to meet the medicine halfway and undo these inactive, maladaptive coping mechanisms so that they can actually feel the way they want to feel. Because if you live the lifestyle of a potato and you have the diet of a toddler who's an alcoholic, then you're not going to feel well, even if you've nailed your thyroid dose. So again, coming back to this point from the start, T4 to T3 is primarily converted in the liver, and patients who drink alcohol regularly or who binge drink on weekends will not achieve optimal thyroid outcomes regardless of their dosing protocol. You can pick regular alcohol consumption or having optimal thyroid function. You can't have both. You can pick one. So I would recommend cutting the booze. So patients with severe Hashimoto's thyroiditis who have had a thyroidectomy, meaning the thyroid has been removed, have significantly better results from split dosing their thyroid. This is because there is no baseline function that we are topping up. So I recommend the second dose is actually taken with dinner. Now, this is going to contradict what I said before, but please hear me out, because this improves compliance. I will tell you what is very difficult for men to comply to long term, and women are probably the same. I don't work with women, but I assume it's the same because we're all humans. Split dosing on an empty stomach in the afternoon is going to be a pain in the ass over the course of someone's life. Compliance is not going to be 100%, and therefore it is better to have a protocol that is suboptimal that's 100%. So I would rather, again, this is just my recommendation, people can do whatever the hell they like, But it makes more sense to have a higher dose in the evening with dinner or before bed. And people think the thyroid will make them sleep worse. No, it improves sleep if you're hypothyroid. It's not a stimulant. You can take it with the food at night, but then offset for the fact that absorbency is going to be reduced by slightly increasing the dose. So this is what I recommend, but there are multiple ways to reach the same destination. So again, I'm going to reiterate this point because people may be confused by this, and someone may have had their own experience where it doesn't line up with this. It's perfectly okay because exceptions don't disprove rules. But patients with severe hypothyroidism will often have improved sleep, not interrupted sleep, when dosing thyroid in the evening because it prevents the hypoglycemia and resulting cortisol and adrenaline spikes while sleeping. Thyroid may be stimulating, but it is not a stimulant like caffeine or nicotine, for example. So T4, as I said before, has a very long half-life, while T3 has a half-life of under a day. T4's half-life is more like a week. So the pharmacodynamics, though, of the peak and the troughs are what are important when it comes to optimizing for stability. However, it is important to note that in most cases, we're not completely replacing the full thyroid function unless someone's had their thyroid removed, which is rarer. We're topping up the baseline thyroid levels, which is why split dosing is optimal, but once daily dosing is often adequate, especially for patients who only need a lower dose. This also helps with compliance. So, as I said, always optimal to split dose thyroid, but some patients may not require this. So, split dosing should also be a consideration depending on how rapidly the patient metabolizes thyroid hormone. I see a lot of practitioners check out at this point because they go, this is too hard, I can't be bothered learning this. But that's your problem. So if someone is troubleshooting thyroid, you can actually measure their blood at peak 1 to 2 hours after the labs, as well as at trough at 24 hours, and you can see if the individual is rapidly metabolizing the thyroid hormone, leading to pronounced peaks and troughs. This can give you a hard evidence-based reason why someone may require split dosing, even if they can't be bothered. So now we're going to get into optimization of thyroid, and congratulations to anyone who's made it this far. So it is much easier to correct hypothyroidism from baseline to get it to the point that it's okay than it is to optimize the dose. It's just easier to get someone in the ballpark. It's harder to optimize it. It's a skill issue. So many times I see clients who've had their severe hypothyroidism corrected. The TSH went from a 50 to a 10, but they are still very obviously hypothyroid because their levels have not been optimized. They went from feeling like garbage to feeling slightly bad. So optimizing Hashimoto's is much more challenging as there is a greater degree of fluctuation of natural production due to stresses impacting the levels of the antibodies, therefore impacting T4 to T3 metabolism, as well as thyroid hormone output from the gland. I'm going to use an analogy from Game of Thrones. If anyone hasn't watched Game of Thrones, you should watch Game of Thrones. And if anyone is planning to watch it after this lecture, and that's the thing you take away from this, which is totally fine, I'm not going to spoil it. But for people who have watched it, if you imagine that you are the castle of Winterfell, and you've got the Dothraki, which are your army, defending you from the White Walkers. So the Dothraki is your immune system, and the White Walkers are diseases, viruses, bacteria, whatever. The problem that we have with Hashimoto's is the Dothraki, which for people who haven't seen Game of Thrones is kind of like the army defending you. Instead of attacking the enemy, they're attacking your own castle. They're attacking you. This is a problem for multiple reasons. One, you're under attack from your own army. Two, your army is basically distracted, so you can be flanked by the enemy from behind. And three, they're going to be exhausted and tired because they're already fighting a battle before it's even started. But most importantly, that attack on your own system is stressing you, and it's actually causing damage to yourself. So when it comes to looking at Hashimoto's, one of the things that we can do to assess and validate the diagnosis and to see how severe it is to actually ultrasound the thyroid. Because when you ultrasound the thyroid, you can see if there is a goiter, you can see if there is swelling, and this will confirm that that army is actually attacking you and they've caused damage to your own castle, or in this case, your thyroid. So this is more challenging because the degree in which they are attacking will fluctuate based on the stresses that are driving the autoimmune response. So when it comes to optimization, a patient has a functioning, and let's just assume that the TSH feedback is functioning properly. What we will be looking at is a TSH that is below 1, ideally close to, let's say, 0.2 to 0.6 when the medication is peaking in the body, which is where I prefer to measure these levels. And we will also ideally see that reverse T3 is at the lower end of the range. So what we are looking at here, to come back and close with my analogy here of the water, is there are various presentations that we can see in the lab testing for thyroid. So what we want to see, as I said before, is the glass to be completely full and there's no signal to the waiter to come and top the glass up. This means the TSH is low. T4 is typically mid-range because it's not over-converting to reverse T3. So this will often be a 15 to a 20 picomole per liter, or if you're in the US, a 1.1 to a 1.8 nanogram per deciliter. And when it comes to free T3, again, depending on if you're measuring at peak or trough, I prefer to measure at peak, your T3 is going to be in the top quartile of the range or even above that because you're looking at a peak of a hormone value that often needs to be above range for it to be optimal because just like with testosterone, the range is often too low. So in Australia, we use picomole per liter. So this will typically be a 5.5 to a 7.5. The top of the range usually goes up to about a 6.5 or a 6. And in the US, if you're looking at picogram per mil, you're going to be looking at a 3.5 to a 4.8. But it is very common for people to need higher levels of T3 than that, as long as their TSH doesn't become suppressed. Now, again, sometimes you do have to suppress the TSH in certain more niche conditions, but if the T3 is elevated, but the TSH is not suppressed, it means that your body is either still signaling to the waiter or that glass is not overfilled. So even if the T3 is 50% higher than the reference range, if the TSH is not suppressed down to nothing, it means that glass is not overflowed. So you can have some feedback here. Now, in other scenarios, what we have is we will see that the glass is full, so T3 will be elevated or optimal, but you'll still have the customer signaling to the waiter to say, hey, give me more water. And what this will look like is a high T3 and a high TSH. So TSH can be 2.5, 3, 3.5, for example. This is usually a reverse T3 issue. And if reverse T3 is elevated, as I said before, we want to look at holistic interventions to bring the stress down. From a supplemental standpoint, this is where KSM-66 ashwagandha can be utilized. Some people are afraid of that, but I don't prefer to use botanicals as a frontline. I prefer to use things like high doses of magnesium glycinate, 300 to 400 milligrams twice a day, not once a day. Things like L-theanine twice a day can be helpful. Phosphatidylserine, 300 to 400 milligrams twice a day or 600 milligrams before bed. CBD oil, 1/4 milligram to 1/2 milligram per kilogram of body weight before bed. CBDA, which is raw CBD, 25 to 50 milligrams in the morning can be very useful, and increasing the intake of glycine, whether this is from collagen, gelatin, or straight glycine, aiming to get an extra 5 to 10 up to 15 grams of that a day. But the supplements alone will not fix the root cause of the stress. So if someone is highly strung and worked up from overtraining or psychological stresses or undereating or all of these factors, you can take all the supplements in the world, but they won't fix it. The supplements are there to supplement your approach to fixing the stress. The third type of presentation, if we're using the glass of water analogy, is when the glass of water is empty or half empty, and the customer at the restaurant isn't signaling to the waiter to say they need more. So this is when TSH is low and T3 is also low. This is when this feedback mechanism is not functioning properly, and this is often to do with a pituitary issue, something like empty cellar, for example, where the pituitary is not signaling to the thyroid to make more thyroid hormone. So in this scenario, we often have to titrate up the thyroid hormone but we're not going to get the feedback from the body when the glass is full because the TSH is not being properly produced. So this will often result in a suppressed TSH when this glass is full. And this requires more gradual titration of thyroid hormone, which is much more advanced and a much rarer condition that comes up a lot less often. So again, I'm going to reiterate a couple of those points for people who may have missed them. So when the patient has had a thyroidectomy, or there is severe damage to the thyroid from Hashimoto's, or there is a pituitary issue, TSH will often have to become undetectably suppressed in order to fill this glass up. So the question can be, well, how do I know when the glass is full or when it's too low or when it's overflowing, when that TSH loop is not functioning properly? One, practice and experience in the field. This is an area that people need to hone their craft by actually doing this. But it's always good to titrate up gradually and work slowly. But another additional thing that people can do, and people may disagree with this, they may find this controversial, but that's fine because it's worked for me and my clients as well as the doctors I've mentored over the years, is this is where you can use waking temperatures. So waking temperatures is what used to be used before we could measure thyroid hormone in the blood. It is not a perfect means of optimizing thyroid. It does not replace blood testing, but it will give you a signal if the thyroid has been overshot. The problem is that there are other factors that will impact waking temperature being too low, but an optimal thyroid will tend to result in a waking temperature of 97.8 to 98.2. This is obviously Fahrenheit. If it was Celsius, you'd be well dead. So what can be helpful to work out if this glass is full or has overflowed or is approaching overflowing is if waking temperatures are above a 98.2 consistently on a 7-day average. So this is getting into much more advanced niche issues. These are 1 in 20, 1 in 50 thyroid cases. Most of the time, that feedback loop is functioning properly, but people do need to be aware of the fact that it may be offline and there is more nuance to these more advanced conditions. I'm not using this to sell my services, but if people want to be mentored on this, you can reach out to me via my website. So increasing thyroid hormone gradually until slight overstimulation occurs and then reducing the dose may be required for some patients to optimize treating more difficult cases, but I think you are much better off avoiding that and working up to the point that that is not needed, because overshooting and working back down is one way to find where that line is, but it is not the best way for the patient's health and safety. But this is why you work up in tiny increments when you are approaching the end goal of thyroid optimization. So coming back to some more kind of optimization troubleshooting points before we finish today. When T3 levels drop by half or more over a 24-hour period, as indicated by peak and trough measurements, I personally prefer to, if I'm only getting one measurement, I like to measure peak, but you have to know if you're looking at a peak or a trough because the levels are going to be different. Some people also prefer to get a 4 to 6 hour steady state. That's cool if that's how they do it too. Different practitioners will have different preferences based on what they like, but I don't find trough measurements that helpful in isolation, only if it is contrasted with peak. But if people do it differently and they can get good results, that's fantastic. So if they drop by more than 24 hours, by half, over a 24-hour period, it is likely indicating that split dosing is required. So a dose increase of something like 20% to offset for a full stomach in the evening is something that you can look at. And then the dose, in my opinion, should be split relatively equally. And if there is an uneven split in dose, it makes more sense for the morning dose to be higher because this is more in alignment with the circadian rhythm. The goal of thyroid treatment is symptom resolution. The numbers that I've spoken about are a guide. They are guideposts. They are a template. They are a rule of thumb. But it is important to optimize symptoms, but it is also important at the same time to not throw a bunch of extra thyroid hormone at symptoms that are coming from other things, whether they are secondary medical conditions, other hormone deficiencies, or diet and lifestyle deficits. So this is why it's so important to work with patients or clients holistically and understand that thyroid or testosterone replacement therapy is a piece of the puzzle. So some more additional points. So Men with age-related testosterone decline will often have a degree of thyroid decline, as I said before, and they will benefit from 30 to 60 milligrams of NDT. Again, credit to my friend Jay Campbell for putting me onto this many years ago. My friend Dr. Keith Nichols is also a pioneer of this field too. And if practitioners are wanting to learn more about this approach, I would highly recommend you check out Dr. Neil Rousier's training courses. So occasionally up to 120 milligrams of NDT can be needed for these cases. But remember, if 4 grains, which is 240 milligrams, is a replacement dose for most people, it is rare for someone who's got age-related hormone decline to need a full replacement dose of thyroid. But again, because there's individual metabolism variability when you take something orally, this is a rule of thumb. So if you're using T4, T3, this can often look like 50 to 100 micrograms of T4 and 10 to 25 micrograms of T3 to restore youthful thyroid hormone levels to offset the age-related hormone decline. This is very important for supporting androgen receptor function, aromatase and estrogen receptor expression, and improving insulin sensitivity, as well as protecting the heart and the brain. So, med on TRT will not feel dialed in unless they have optimal thyroid function, which ideally will occur naturally, but as they get older, the chances of that are lower. But it's so important that the thyroid is properly evaluated for, because if this is missed and overlooked, this is a very common cause of these estrogenic side effects that you hear about due to the metabolic dysfunction, increasing aromatase and upregulating estrogen receptors, as well as increasing the production of prolactin and cortisol, which downregulate 5-alpha reductase and therefore less total overall androgens. It's much more complicated than just throwing an anastrozole at people who have metabolic issues, and I've seen this all the time for the last 6 years. So hypogonadism often causes a slight increase in TSH, which is corrected by fixing the testosterone deficiency. This is why it's important that thyroid in younger men should be introduced later in treatment if autoimmunity or age-related decline is not present, as thyroid dysfunction is likely secondary, not primary. If someone is older with age-related hormone decline, it makes a lot of sense to introduce them with a small dose of natural desiccated thyroid. This is something that my friend, as I said before, Dr. Keith Nichols has done a fantastic job with, to balance all the hormones in the system to allow people to have the best possible response from day one and titrate from there individually based on what they need. So all TRT clinics should be assessing a full thyroid panel, including Hashimoto's antibodies, when onboarding patients and assessing them for hypogonadism, due to the role of thyroid in optimizing TRT treatment outcomes, prevention of side effects, and the similarity in symptomatic presentation of hypogonadal and hypothyroid patients. Again, Dr. Jordan Grant, Justin Grosset, Victory Men's Health in the US. These are the people who I recommend seeing. Max Draper at Alphagenics in the UK. If you're in Europe, and hopefully soon, or at the time that you're watching this video, Scandinavia, you can work with TRT Baltic. If your clinic, and again, I don't have financial relationships with a lot of those clinics, they are just colleagues of mine who know what they're doing. If your clinic is not looking at your thyroid labs when you're onboarding, they are doing you a disservice, and there is a good chance that they will be doing you harm by missing something that is important. Some TRT cases are very straightforward and just require TRT, but that should be determined based on ruling other stuff out, not making this assumption, which is what I've seen with so many guys coming to me, thousands of men who I've worked with for the last 6 years, who are having troubleshooting problems from issues that they had overlooked when they were onboarding for TRT, because it's easier just to sell men testosterone because all men want more masculinity. So that will conclude today's masterclass. There will be additional bonus content, including case studies and further discussion of avatars of how thyroid optimization plays out in the TRT Masterclass expansion video. You can find this in my TRT Academy, which is my school group. You can join this group to learn more about everything I do with hormone replacement therapy, group calls I offer in that group twice a month, as well as twice a week Q&As where you can upload your questions in advance, and then I reply to all of them with extensive video responses so that I can give people as much time, effort, energy, and attention as needed to answer your questions. And this also has all my written content, all my exclusive video content, which is where I primarily post. I don't do as much on social media and YouTube as I do in my academy. So if you would like to work with me via that means or have more access to resources on thyroid and everything else to do with hormone replacement therapy and my approach to coaching men, you can join the TRT Academy. That is everything that I have for today. Congratulations if you made it through to the end. As I said, you can check out my Beyond TRT ebook or lecture if you would like a summary of this to refer back to. That is everything I have to share with you today. Thank you for watching, and I'll see you all on the next one. Daily injections are ideal because this gives you ultra stable testosterone levels. If you can really frequently administer something with a very long half-life, you can keep your levels super, super stable. And I think that this is the most beneficial way to do TRT. However, how should TRT be administered? So TRT should be administered as frequently as possible.